new, we can do that yet.
Watch it, you don't get into the system and you get tired.
It's going.
Are we good?
Yeah.
Alright. So, some of the other respiratory diseases, pneumonia. It's really important when you guys are assessing someone with various lung symptoms, identifying if they have heart failure or if they have pneumonia. Remember, with pneumonia, it's usually unilateral breath sound issues, abnormal breath sounds that you're going to hear. Patient's going to say, hey, I haven't been feeling very good. Lightheaded, weak, dizzy. Did you sign in on the bottom of mine, by the way?
No, I don't think I usually just sign this.
Oh, that, okay, as long as you have that, I'm sorry. They're going to be coughing up sputum. They have a productive cough. And there's really not a whole lot you can do for these patients. You might be able to give them a albuterol adjuvant to like open the bronchi a little bit to help them cough out some of the mucus a little bit, but that's about it. But big thing, never ever ever give these people Lasix. The empyema in there, it's almost like if you take oatmeal and you make oatmeal in the microwave and you don't put enough water in the oatmeal and how it gets kind of gunky and hard, that gets in between the alveoli and the alveolar capillaries and it kind of pulls out any fluid and leaves that gunk there, and it makes it very difficult for someone to recover if you give these people Lasix and try and get them better. Our next patients are asthmatics. Again, they're a type of obstructive disease. Air goes in, it doesn't come out as easy. Patients, you know, you'll see that delayed kind of upstroke on your end tidal. That's because, remember, your end tidal is ultimately measuring the alveolar air. And that's where it should be at its highest for when you're deep down into your lungs. But it takes a little bit of effort to get that out. It's slow to come out because of the bronchospasms. With these patients, for adults, we go ahead and we give them the albuterol and the adjuvant. But if they've been taking their own albuterol treatments and it's not working, it's not that you can't go ahead and ask medical control early on to give them the epi. So I know our protocol says albuterol adjuvant. If that's unsuccessful, another albuterol adjuvant. Unsuccessful, albuterol treatment. If that's unsuccessful, then go to the epi. Contact medical control. My recommendation is if you go ahead and start the adjuvant treatment, I'll go ahead, or albuterol and adjuvant, I'll call medical control. We'll get epi on board, sooner the better. Pediatrics. What is the dose, what do we give for pediatrics that the albuterol, the epi isn't working? What drug? You guys remember? Meg sulfate? Yeah, what's our dose? Anybody remember that?
25 milligrams per kilo.
Yep, 25 milligrams per kilo. You get the gold star for the day. So, not uncommon either for them to end up needing steroids. Solumedrol is probably the most common one that's used pre-hospital. But again, it takes a little bit. It just reduces some of the inflammation. We do not carry that pre-hospital. Yeah, and there's where it talks too. Status asthmaticus, bronchodilators. Remember though, when you're listening to lung sounds, if you're listening down in the basses and you're not hearing much, and they're having an asthma attack, that's a bad thing. Because they're so clamped down that air movement is not occurring. You need to figure out how to get that medicine deep down in those lungs for them to go ahead and be able to breathe. Our COPD patients, chronic bronchitis, our blue bloaters. Again, you're going to have productive cough with these patients. They're going to have kind of a barrel chest because of the COPD. Doesn't always let air out. If they're having difficulty breathing, you can go ahead and give an albuterol adjuvant treatment. Nothing's wrong with that. Dilate the bronchioles so that you can move some of that mucus. Emphysema, usually no productive cough. There are pink puffers. They like to purse their lips. Remember, the elasticity of the lungs is decreased. The alveoli collapse in certain areas. And so they purse their lips to create their own PEEP as a way of keeping the airway open. Again, they're having difficulty breathing. Albuterol and adjuvant really is all we have for these patients. CHF. So, you have a 62 52-year-old male patient who calls you at 5:30 in the morning. Difficulty breathing. When you get there, he's sitting on the edge of his bed, feet are dangling, and he's in that tripod position. You can hear him from across the room. He's wheezing, but when you get closer, you can kind of hear gurgling sounds too, or fluids in the bases of his lungs. Remember with these patients, get a good history, because old geezers do not become new wheezers. So many people say, oh, I hear wheezes, gotta give them albuterol and Atrovent. But that's not what you want to do for these patients. They're not wheezing because the bronchioles are constricted. They're wheezing because there's so much pressure from the lungs that the bronchioles are collapsed. It's like kind of flattening out a straw a little bit, and the air going through it is giving you that wheezing sound. With these patients, you know, if they've got a cardiac history and a respiratory history, you're kind of like, which way am I going? But do they have pedal edema? Do they have the rails in the bases, wheezes up above? Give them the nitro, and then do the CPAP. And it's really important, you guys, start the nitro in the house. Give them the nitro, put the CPAP. By the time you get them out to the ambulance, another nitro is ready to begin. Check the vitals, give them another nitro, and then continue on with the CPAP. By the time you get to the hospital, they're going to probably be ready for another nitro. Check the vitals, give another nitro before you go inside. You want to make sure you're getting those nitro on board, because that's really what's going to help them breathe a little bit easier. Lasix is in here. Be cautious using Lasix. I know that it's in our protocol. It'll probably go away, but who usually has CHF? It's our elderly patients. Our elderly patients usually have very poor intake, and they're generally dehydrated, more so. I mean, maybe not overly dehydrated like if they're sick, but they're generally dehydrated. And so you go ahead and you give them Lasix for someone who's already dehydrated, can cause issues. Remember, Lasix will take 20 to 30. I do know that we use it for venodilation for our CHF patients, but it also goes ahead and causes a little bit more dehydration. There's nothing that says that it's really that much better for these patients. You have an adult respiratory distress syndrome where you have infiltration into the interstitial space. Not much you can do for these patients. We usually see this come from patients who have been on long-term pneumonia, been on the ventilator for a long period of time. Not a whole lot you can do for these patients pre-hospital. Patients with pneumothorax, tension pneumo, again, what do we got here? Do we have a simple pneumothorax or a tension pneumo? Very tall, thin men are very prone to having a spontaneous pneumo. If that's the case, they may complain of sharp chest pain, difficulty breathing. With them, though, we're just going to monitor them. The difference between the simple and the tension is going to be blood pressure. That's what you're really looking at, is hypotension. You've got someone whose blood pressure is a little bit lower, JVD, tracheal deviation, really bad sign, late sign. Hopefully you guys don't see that pre-hospital. We go ahead and do a needle decompression. Whatever the affected side, in between the second, third intercostal space, atop the rib, underneath is where all the vessels and the nerves are. Want to stay away from that. We don't use the flapper valve anymore. We don't use the tip of a glove. We just leave it open. If it ends up closing off, you can go on the other side either way just a little bit and go ahead and do it again. Hyperventilation syndrome. Someone starts to hyperventilate. They're breathing very fast. If it's too bad, they start getting carpal pedal spasms, so their hands start to cramp up. What do we do for these patients? Well, our coaching, yeah, that's about it, right? Need you to calm down. Breathe in with me. Take a deep breath in, hold it for 5 seconds, now exhale. That's really what we have. If someone, though, is so bad, we do not want to put them on a nasal or a non-rebreather with no oxygen. We don't want to give them a paper bag. That can cause damage to them. What you can do, though, is to go ahead, if they're so anxious, give them a little bit of Versed to take the edge off. Hopefully that'll slow down their breathing. But if they're hyperventilating because they're having anxiety, that could be, you could go the Versed route too. Those with CNS, spinal cord, respiratory muscle, as I was telling you before, you have someone with a spinal cord injury. Maybe they're breathing very shallow. Remember, the minute volume for a patient is about 6,000 cc's. And so you want to make sure that they're getting good air movement at a good rate. If they've got spinal cord injury, they might be breathing very shallow. Someone who's overdosed on some narcotic, they're breathing very slow. And I'll talk to you guys about the Narcan here in a minute, but we want to ventilate faster for them. Go bag them at 10 to 12 breaths per minute. You know, what do they look like? How are we going to manage them? Okay. So this is our carbon monoxide protocol. Not much of a protocol. Anybody who has carbon monoxide, we're going to give them 100% oxygen. Again, remember, carbon monoxide has a 200 times affinity to oxygen, so it's going to bind to the hemoglobin a lot better than what oxygen molecules are. And they ultimately need to be at a hyperbaric chamber. Who's got the hyperbaric chambers around here? Lutheran? Yeah, otherwise you're up in Wisconsin at St. Luke's. They've got the largest one in the Midwest here. I think they can fit 24 to 27 patients in theirs. But down here, you guys have the Masimo's Rad 57s?
Yeah.
Yeah. So you guys can make the determination how much carbon monoxide a patient has. You're there, you've got one person who's complaining of flu-like symptoms, and then someone else in the family. Yes, a whole family can be sick, but to have the exact same systems, make sure you're checking everything out to make sure it's not carbon monoxide.
Got CO detectors on all the beds.
Yeah, which is really nice. Altered mental status. It is your job to figure out what is going on with the patient. Why are they having the altered mental status? Is it hypoxia where they can't breathe? Or is it drug overdose, glucose problems? You know, years ago we used to give an AMPA-D50, 100 of thiamine, and 2 milligrams of Narcan, all at once, without figuring, and we hope one of them woke them up. Now we at least go through and try and figure out what's going on before we start pushing any medications. We know if the glucose level's under 60, give glucagon or an AMPA-D50. If we suspect that it's a narcotic overdose, why do we give Narcan? We give Narcan just to improve the respiratory rate. And I'm going to pick on the cops again. Well, let me ask you this. How much Narcan do you give a patient? Is it 2 milligrams or 4 milligrams?
We don't carry Narcan.
You don't?
It might be in our bag in the back, but not that I'm sure of right now.
Okay.
On my body, I don't carry Narcan, no.
Your guys carry it? Your cops
Our
carry
cops
it?
have it. I don't know if they carry it, if it's just in their car.
Is it 2 or 4 milligrams, you know? Yeah, the thing about the Narcan, everybody's like, oh, it's so benign. It's not benign. It can cause non-cardiogenic pulmonary edema. But, you know, I keep telling people with the Narcan, give them just enough to make them breathe faster. You know, increase the respiratory rate. You got someone who's unresponsive, pinpoint pupils, they're breathing 10 times a minute, pulse oximetry say is 94. You know what? I'm going to leave them be that way. I'll monitor them on my way into hospital. Respiratory rate starts to decline, yeah, I'm going to give them some Narcan. I'm going to give them enough just for the respiratory rate to kind of make its way back up. But I don't want to wake them up. I don't want them coming out swinging. I don't want them vomiting. I don't want them seizing. I prefer to have them nice, supine, nice quiet trip on the way into the hospital. I know that a lot of the drugs, though, that are out there today, there's so many things that are mixed, and I've heard some of the cops are giving up to 4 milligrams of it, and they're just 2 milligrams up one there, 2 milligrams up the other. It's like, whoa. You know, if this patient is breathing at 4 times a minute, and has been breathing at 4 times a minute for the last 5 minutes, they're probably starting to become acidotic. And by doing a quick shift, that can cause pulmonary edema, the semi-permeability of the blood vessels to occur, and then fluid gets in, and then you got another set of problems. To be very honest with you, you should be bagging these patients first for about 5 minutes before you're pushing the Narcan. Try and get them back to homeostasis before you're pushing the Narcan. Because really, Narcan is all it is to improve respiratory rate. Monitor them. Watch them. Okay? I always love it. Oh, there's a needle in the arm. They're talking to you. They just shot up with heroin. Oh, slamming that Narcan. Why did you do that? They're talking to you, you know? Wait till they go unresponsive to start administering it. Adult asthma, COPD. This one again, you don't have to go ahead and follow it to a T. Albuterol adjuvant. Albuterol adjuvant, another albuterol adjuvant, albuterol, and then epi. You know, do what you feel is best for your patient. Yeah, one of you can start the DuoNeb, but it wouldn't be a bad idea to contact medical control and ask them for that epi. Yeah, my patient, they're not over 40 years of age, or they don't have a cardiac history. Yes, they're tachycardic right now, but they're tachycardic because they can't breathe. You know, and explain that to the doctor. Epi is one of those medications given at IM that doctors get a little bit worried about administering because they don't want you to give it to someone with a cardiac history, or if they're having a cardiac history, it can cause a lot of problems for them.
So you said the epi, right?
What's that?
The epi,
Epi?
that's what doctors don't like.
Yeah, they don't like it. I wish we'd give Tributaline. Tributaline has the same effects of epi, but doesn't have the same cardiac effects usually. But it's just another drug to carry that they don't feel that's necessary, I guess. But epi, I usually, if I have to give epi, I'm like, you know what, this person, they don't have a cardiac history. Yeah, they're tacking along at 120, but they're tacking along at 120 because I just gave them a albuterol treatment. They're having a hard time breathing. I want to get the epi because I think that's what they need. You know, the tachycardia isn't. And you can pretty much, if you talk to the doctor like you know what you're talking about, a lot of times they'll go ahead and let you push it. So can be used. You can use CPAP for patients with COPD, and the neb treatment set up along with it. So don't forget about adding that. Patients with pulmonary edema, they're stable. As I was telling you before, patients with pulmonary edema, a lot of them will have very high blood pressures. You know, it's not uncommon, 190 over 110. We've got to reduce the pulmonary pressure. That's what's causing the pulmonary edema, the semi-permeability of the vascular. Give them the nitro, and make sure you're giving them 3 doses of it. Not all at once, but, you know, every 5 minutes. Get that CPAP on them. Lasix, yeah, I really wish they'd remove it, but if you are giving Lasix to someone, bless you, and they don't normally take Lasix, we give 40. If they do normally take Lasix, we double it and give it 80. But just be careful giving the Lasix. If they're unstable, we go to the the cardiogenic shock protocol, and we monitor them with blood pressure. There was actually some pretty good information coming out lately that with dopamine, it's called push dose epi, and it's administering epi IV instead of administering dopamine to help raise blood pressure up. I just started reading the other study that goes along with it, but it sounds pretty promising. It sounds pretty good, for that matter. So our medications, albuterol, sympathomimetic, beta-2 adrenergic agent, dilates bronchi, relaxes the smooth muscles. We use it for bronchospasms, wheezing, to go ahead and dilate the bronchioles. It works pretty quick. I didn't think it lasts 4 to 6 hours, but it could be. Some of the things that we have to watch for: tachycardia, high blood pressure, anxiety, restlessness, shakiness. That's all pretty common as someone, if they take an albuterol treatment. Now our Atrovent is also an anticholinergic along with a bronchodilator. Ignore the hypersensitivity to drugs, soybean, peanuts, and atropine. Yes, the drug in the atropine is good, but the soy and the peanut, they used to make Atrovent with a derivative of soy and peanut. It is no longer made that way. It hasn't been for probably about 10 years right now. So if they have a peanut allergy, nothing you have to worry about at this point. So Bronco Smooth Muscle Relaxer, okay, inhibits vagal receptors by antagonizing the ACH, which mainly increases contractility and constriction. Don't forget about your inline nebulizer. If you've got someone unresponsive due to an asthma, you can bag in a neb treatment. You can use your bag valve mask. You can use it on a King tube. If you guys don't already have it set up, get it set up in a baggie. I watch too many people trying to struggle putting it together. Duo Neb is just a combination of albuterol and adjuvant. Lasix loop diuretic works in the loop of Henle. Again, as I told you before, initial dose is 40 unless they're already on it. And then we give 80. And venodilation, fairly quick, 5 minutes, but the diuretic portion takes up to 20 minutes. Again, be very careful with these patients that they're already not dehydrated. Narcan, an opiate antagonist, it blocks the opiate receptors so that the opiates cannot attach, therefore giving someone the high or what they were getting out of it. We use it for someone who has respiratory depression due to a narcotic overdose. That's it. Just because they've taken a narcotic doesn't mean they get it. You also have to be very careful with your elderly patients. Sometimes they're in nursing homes and they're on, some type of Percocet or something for pain management. They've probably been for a very long period of time. Going ahead and pushing Narcan full dose, a lot of it for these patients, can send them into withdrawals, which they've been having for years and years. You have to be very cautious. You don't want them to seize and vomit on you. Racemic epi, we do what I kind of describe it as ghetto epi. We take regular epinephrine and we nebulize it with saline. But racemic epi has both alpha and beta effects. Remember, alpha effects, it works with the heart, increases contractility, increases the conduction through the heart, where the beta, it goes ahead and bronchodilates, relaxes the smooth muscles. Also alpha effect, vasoconstrictor, but it reduces subglottic edema, helps dry up that edema in that subglottic area. All right, anybody have any questions? Okay. Oh, I gotta make more copies. You're a basic, right?
Correct.
Okay. You can take one if you want, but
You can help me?
he can help you.
So you got the same stuff.
Oh, I understand.
That's quite the new system you guys got there.
Long overdue.
Yeah.
Alarm investigation, Chinese pharmacy.
All right, boys. How's it going?
I'll give you the answers and then you can give them
Good
when
morning,
you're back.
alarm investigation.
I'll circle all your stuff.
736 Elm Street, group 2806. 736 Elm Street, alarm investigation engine 28.
You want the answers?
Sure.
Helpful.
All right, 1,
Hang on. All right, C.
1 is C, yes.
And 2 is A,
Yep,
3 is D.
C.
C. Yep. You know, cause
Oh, yeah, because I said 25, it's 2 grams. Wait a minute, no. D is Ah, shit. I don't know what the protocol says. Oh, here's the protocol, right here, let's look real quick. Yeah, 'cause it's...